Hello, this is Fred Goldstein with Health Innovation Media, and I am at the MGMA conference, and I'm joined by Robert Tennant of MGMA.
Great, welcome. I'm happy to be here. Looking forward to an interesting discussion.
Yeah, it's a pleasure having you here. You just recently told me you've got 22 years with MGMA, so tell us a little bit about the organization shortly and what you do for them.
Sure. MGMA was actually formed back in 1926, really formed by the Mayo brothers. We all know the Mayo Clinic. The idea was they wanted to bring folks together to talk about the issues that were important back then, and nothing's changed at all. Members come to MGMA to learn, to network, to commiserate, and work together to solve a lot of problems. So I've been with MGMA 22 years. We created a very robust government affairs department back in 1997, and I was happy to be part of that. And I've taken on the portfolio of health information technology, and I lead the association's advocacy efforts in that area.
So you're working up on the Hill, and obviously nowadays a lot of effort on the Hill around healthcare. It's a big issue for Congress from a lot of reasons, sure. But in particular we have all these IT vendors, and this whole issue of interoperability has come up. And what are you seeing now in terms of legislation around interoperability, or how that might impact various providers out in the community?
Sure. Well, what was interesting, in 2016, there was the 21st Century Cures Act, which was a rare thing in Washington. It was known as a unicorn, which was bipartisan, bicameral healthcare bill. And it was widely supported on both sides of the aisle. And what it did was it tried to promote interoperability, the movement of data between care settings in particular, to try to improve healthcare. And of course it did a lot of other things. What then happened was the Office of the National Coordinator of HIT then released in the spring regulations to implement the 21st Century Cures Act. Now that's where we have some challenges. We put a very voluminous comment letter to ONC, raising a lot of issues about the potential unintended consequences of data moving that isn't fully protected and isn't fully secure. So one of the things we've been pushing for is what I would call the appropriate movement of data with the patient as at the center, but making sure that that information is kept secure.
Yeah, this was really about freeing up data. I remember when Don Rucker talked about, we're going to free up the data, get it out to the consumers, give them the ability to use it, analyze it, correct, as well as make sure that it flowed between all these various systems out there. Yeah. So as you looked at it, there were some issues that you found specifically about security of that data.
Yeah, one of the visions of ONC and Dr. Rucker is that patients would be able to literally pull out their smartphone and have full access to all of their health information. The proposed rule will tell practices that they must, by law, share that information with a third-party app at the direction of the patient, which is well and good, except your viewers, I'll ask the question, how many people read the terms and conditions before they hit I accept to that app? So we're concerned that there may be inappropriate disclosures of information, that information may be commoditized, sold, but also there could be some negative impacts potentially on employment. So if an employer says to their staff, you must download your information to this app, now the employer has access to potentially mental health issues, substance abuse issues, right, cancer treatment, all the things that could impact their employment.
So really, when you think about this from a technological side, it's not the issue so much from the providers themselves, but as I've talked about in others, you have all these multitude of apps out there, and who knows how secure they are, whether or not they sell it like you talked about, or even which server it's sitting on in what country, and that's what you're trying to fix.
Exactly, and the problem is the vast majority of these third-party apps are not HIPAA-covered entities, so they're not bound by any law. And so what we're telling the government to do is, first of all, there should be transparency for the patient. The patient should be aware of what their app is going to do with their data, and what security protocols they have in place to protect it. The other option is to look at a certification process. So before an app could be considered for use for hospitals, for practices, for other care settings, they would have to prove that they have met a minimum level of security.
And obviously interoperability, we're now, I think, beginning to make some good progress on it. There's been a lot of push. So we're seeing these linkings up. Where do you see that, and where do you see the political process moving in terms of that?
There's tremendous opportunity. I know we've raised some concerns about it, but the opportunities to share data for improved care coordination are significant. So for example, on the CMS side of the rulemaking process, they have now required hospitals to make available the admit, discharge, transfer information to the primary care physician. That will allow, for example, in value-based care arrangements, better tracking of patients, better care coordination. So if you know that your patient who is a diabetic went into the ER on the weekend, you can follow up with them to make sure they don't go back the next weekend. That's tremendous opportunity for better care and lower costs. But there's still a lot of work to be done. And in fact, two members of Congress, Representative DeGette and Upton, one a Democrat, one a Republican, are now looking at a potential Cures 2.0. So maybe addressing some of the issues that weren't addressed in the first law, and maybe addressing some of the concerns raised in the ONC final rule, which could come out as early as, let's say, the end of this year.
And let's talk about the technology a little bit, from the idea that you've got providers at various levels of experience with multitude of different platforms, but the technology itself can really serve as an integrator, whether somebody is using a fax or using another machine, and be secure. Are you seeing that?
Yeah, it's a slow process, especially for smaller practices. To move to fully integrated practice management, EHR software is very expensive. So a lot of them are moving incrementally. But there are some real advantages, and not just on the clinical side. The interoperability side is fantastic, but there's also some operational efficiencies to be gained by the technologies. So for example, there are transactions that automate many of the manual processes that practices go through: submitting claims, checking patient insurance eligibility, checking the status of a claim, getting paid electronically through electronic funds transfer, getting the remittance advice coming back from the health plan. All of that can be automated, which frees up staff to do more patient-facing activities. But it takes an investment. And so I think practices are always looking at the ROI. What's the value to the practice, both clinically and administratively, and can I afford to make that investment?
You talked about the next phase and some of the work now being done in Congress with the potential second act here. What are the key issues you think they need to begin to address to help the industry itself create this interoperability?
Well, obviously privacy and security. The concern that we have is that 2 or 3 major breaches of health information exchange entities could put the brakes on interoperability, which we don't want. But the other main issue is identifying the patient correctly. So is the patient Rob Tennant the same as Robert Tennant? If I have 2 or 3 homes, I have different zip codes. Maybe I put my zip code for work on one visit, and the other one I put my home. Birth dates can be recorded incorrectly. So HIPAA, back in 1996, required the government to develop a national patient identifier, but that's been put on hold because of Congress ever since then. So there's a movement now to free up HHS to work on this issue, because if you don't match the records correctly, you could have a false positive or a false negative, and that could have catastrophic implications on patient care. So we're cautiously optimistic that Congress will address this issue in the current appropriations process, and we'll be watching for that very closely.
Yeah, that whole national patient identifier is obviously a hot topic from a lot of different people's perspectives as to whether or not that's kind of like, oh, we have this now unique identifier, we know everything about us. So, but you feel pretty confident that might move forward a bit.
Oh, I don't know about real confident. I think there's a good chance. There was The prohibition was lifted on the House appropriation side, but there's still some reluctance on the Senate side. So we continue to go up to the Hill to talk to senators, to explain to them that no, this is not an attempt to create a national patient database where the government has full access to your medical records. This is simply a way for different care settings to exchange data with the confidence that that patient is the correct one. And I think without that, we run the risk of, again, where information that is relied on by the physician is inaccurate, and therefore it could cause patient harm.
Really good point. Well, thank you so much for joining us, Rob. It's been a pleasure.
My pleasure, and thanks for having me.